All right, well, thank you guys for being here. I'm happy to give an in-service on esophageal tubes for balloon tamponade of esophageal varices. So there are three main brands of these tubes. So this one is called a Sangstaken Blakemore tube. There is also what's called a Minnesota tube, and a Minnesota tube will have four things coming off of this. The fourth one goes down at the tip, and you're able to suck back to detect if there's blood actually in the esophagus, so you can monitor if there's bleeding in the esophagus or not. So the Minnesota tube is actually a little bit nicer than this one clinically to help you monitor the situation, but we've been stocking the Blakemore here. And then there's what's called a Linton tube, and the Linton tube does not have an esophageal balloon. It only has the gastric balloon. So these balloons, there's one for the gastric and one for the esophagus. And these are helpful if you have a patient that is in an emergency room and you don't immediately have access to GI. They can stop a variceal bleed, package the patient up, and get them to a higher level of care. They're also helpful if you're doing a variceal bleed case and you cannot stop it endoscopically. So you basically have a red out, there's bleeding so fast that you can't suction the blood to visualize where the bleeding's coming from. In that situation, this buys you time to get the patient to a more definitive way to treat the varices, which is going to be usually either a TIPS or a IR procedure like BRTO and things like that. So the tube would come in a box like this. Always in the box are the instructions. And so if ever you forget what is going on, the instructions are here. Please read them if you can't remember. Yeah, there's blood everywhere. And anyway, so the reason that these tubes are daunting for people is the esophageal balloon part. Because if you inflate this to the point where you're applying enough pressure in the esophagus to stop bleeding, you can actually shut off blood flow to the esophagus. And so you can get tissue death or necrosis, and the esophagus can perforate, which is going to kill that patient most likely, because if they already have advanced liver disease, they're not going to be a great candidate for surgery. So that's why they need to be used with knowledge and caution, but I think that they're really invaluable in those couple clinical scenarios that we talked about. Whenever someone is considering using this, the patient needs to be intubated. So they need to have endotracheal intubation, that's for airway protection. The way that people with variceal bleeding die is not so much the bleeding, it's infection. So it's typically pneumonia or spontaneous bacterial peritonitis. So antibiotics and intubation for airway protection are really critical. These tubes typically come with these little plastic things in them. It's just kind of a little like a obstructive funnel just to keep the shape of the funnel here. And sometimes they're really hard to pull out in my experience. Sometimes you actually have to use forceps to get them, to get a good grip on them and pull them out. We've had a good team to put together our kit, and so there are multiple parts here. So the most important thing to recognize is that this tube has each port labeled. This is a 16 French tube, so the diameter is about 5 millimeters. It's pretty big to shove these through the nose, the nasal cavity, so most of the time it's recommended that you put it through the mouth. And one of the things that you will probably want to do is just leave the bite block in place, because if the patient bites down on this tube, you could potentially break the seal and the balloon could collapse. So the goal with this is to apply pressure in the stomach, and you pull up and provide tamponade, so you're applying pressure at the top of the stomach. And the vascular anatomy is really important. I don't know if you want to zoom in on these, but you have the portal vein, which is the vein that's the door to the liver. So all of your guts drain through the portal system into the liver. In a patient who has cirrhosis, there's scar tissue there that's preventing good flow through the liver back to the hepatic vein, and from the hepatic vein back to the heart. So it's that restriction of all that scar tissue in the liver is what causes those high pressures in the portal system. And there's a vein that comes off the esophagus to the portal vein, and there's a vein that comes off the top of the stomach to the portal vein. There's a lot of variability in anatomy in this area. But most of the time, if you inflate the gastric balloon and you pull up and you're applying enough pressure, the variceal bleeding will stop because you're preventing that outflow of the blood of the esophagus back to the liver. So you need to inflate this balloon to 500 cc's of air or milliliters of air. And you need to apply adequate force or traction on the balloon. And usually that is about a 500 ml bag of saline. So 500, 500. 500 in the balloon, 500 mLs of weight off the edge of the bed. That's the easiest thing to do. So they have little pulleys that you can put on the end of the bed. You tie a rope to the tube and usually a clamp on the tube, and then you apply that over here. This kit contains a 5.5 kilo weight here and a hook so that you can just hook the rope on there. This has got a thin slide and a round side and a thin slide, so you slide the weight into there and it prevents it from falling off and hitting somebody's toe. But a 500 cc bag of saline is always going to be available, and that's going to be good.
And some of the references that we had seen, they used an IV pole, and it went up over the IV pole, so it went straight up. Like if you have.
So the other thing that you'll oftentimes see is football helmets or hockey helmets, depending on what part of the country you're in, where they'll apply traction and they'll tape the tube to the face mask of the device. So any of those.
That was in my day.
Yeah, any of those are fine. So somebody usually steals the football helmet, but really just a rope over the edge of the bed is most of the time all you really need.
Where are those little metal things that they put on the end? You know what I'm talking about for the traction pulleys? Those are going to be all up on the third floor. Third? Oh, okay.
So when you look at these, each port is labeled. So there is a gastric aspiration port. That's the biggest one here. So if you're aspirating back on that, you will suck blood from the stomach. So you'd be passing these just like you would a nasogastric tube or a nasoduodenal tube. You lubricate it, you pass it down. Now, one caution is that if you have this folded back on itself in the esophagus, or the patient has a really large hiatal hernia, for example, and the balloon's not in a good position, you can actually, if you start blowing this up to 500, you can rupture the GI system, so either the esophagus or the stomach. So the instructions say you put this under water, you blow it up and test to make sure that there's no leak in the balloon. You don't know, hopefully it's not expired, but this.
Anesthesia sector room 10 now, please. Anesthesia sector room 10 now, please. Oh, thank you, Stephen.
These are made out of latex and they do degrade over time, and so you could have a pinhole leak and then you're in trouble if you're trying to save somebody's life and it's not working. So there's a gastric aspiration, and then there is the esophageal balloon, and then there's also the gastric balloon. So when you're using these, it's really helpful to have what's called a Lopez valve. So this is just a 3-way stopcock, and it's got a little Christmas tree on either end of it there, and just kind of little adapters so that you can plug different things in. So when you have this down inside somebody's body, all right, you would then put this Lopez valve on each of the ports for the esophageal and the gastric. And that will allow you to blow up the balloon. So this is the esophageal balloon, and this is the gastric balloon. So you're doing it with air. So you would just go, we're going to put in 100 cc's of air first in the gastric balloon. You want to make sure that your stopcock is pointed the right direction. So this is a 50 ml syringe. Balloon is going up. I'm going to lock that so the balloon stays. Do another 50 mLs and open up your stopcock. That's 100. Now this is in the patient. It's hopefully in their stomach. You would get an x-ray and make sure it's below their diaphragm at that point before you go to the next step, which is to inflate it to 500. So we're going to keep inflating this. So I'm going to put in another, that's 150. That's 200. 250. No, it's the gastric balloon that you want the 500, a 500. And that's 400. 450. Yeah, this 50 ml syringe is pretty small for this, but probably not going to find one much bigger. So you can see now you have a 500 cc's of air in the balloon. You would test this underwater before you put it in the patient, make sure that you don't have a leak, and then deflate it. And now if it's in position, you're applying tension on this, it's pulling up at the stomach and it's applying pressure. Now at this point in time, if blood is still pouring out of the patient's mouth, so suggesting that a balloon tamponade just from the stomach is not enough, then you can start to inflate the esophageal balloon. So you need a manometer for this. So you need to measure the pressure in the esophagus. And so you would initially inflate this to 50 millimeters of mercury of pressure and leave that to stop the bleeding until the bleeding is stopped. And then you would want to gradually decrease that pressure to 25 millimeters of mercury. That's the goal. 5 millimeters, or I'm sorry, 5 millimeters, 5 millimeters, 5 millimeters, just stepwise down until you get to 25. And if there's sign of rebleeding, then you just go back up 5 and you find the lowest pressure that controls the bleeding. So you can just use a little Christmas tree adapter here. This little funnel kind of plugs in and seals with the manometer. There's this tubing is nice because there's a clamp here. So you can clamp, and right now, this is reading at 0 millimeters of mercury. Just like when you take somebody's blood pressure, you have to close it off, and then you start pumping up the balloon. And I think I'm actually on the gastric port. I am in the gastric port. So make sure you're on the esophageal port. There we go.
Would we be the ones blowing these up, or do you?
Well, I think the physician should probably blow it up to get it to, yeah. So this currently is at 60, so you can see that the balloon is inflated at 60 millimeters of mercury, and then you can just crack this and lower the pressure to say, let's say we're at 40 there, and we leave that balloon in place, the bleeding stops. 15, 20, 30 minutes later, we try to go down another 5 millimeters of mercury. When this is in the patient, this is really more for nursing care. You want to deflate the balloon at least once check the pressure every hour, and then you would deflate the balloon every 12 hours, both balloons, to check to see if the bleeding has stopped. And if the bleeding is persistent, then you would just blow the balloons back up to where they were before. It's actually not that complicated. The hardest thing is just making sure you have all the parts and the hardware in the kit. So our Blakemore kit is labeled as having 2 sphygmomanometers, 1 large 60 cc syringe with a short tip, 1 60 cc syringe with an NG tip, 3 plastic catheter clamps, a Lopez valve, a 1-pound weight with hanger and rope, 3 plastic hose connectors, and 1 NG tube connector, Christmas tree type, and the Blakemore tube. So when you have these in, you can, when you have your balloons at the pressure or the volume that you want, you can close your valves so that you don't have leakage. You can also clamp it here, and you also can control the pressure here. So
when you're checking your balloon volume once every 12 hours, are you wanting to do 1 balloon at a time to prevent movement up the tube?
So I would definitely deflate the esophageal balloon at 12 hours just to make sure that if you don't need to have it up and the bleeding is stopped, then great. Again, it's a temporizing measure to get them to higher level of care, to TIPS, IR, things like that. You could also deflate the balloon. I don't think it's going to move much. These blue clamps are helpful. You can also pinch off the tube so that you don't have leak. And then it's also helpful that you can tie the rope through one of the loops here, and then that is where you attach it to your weight. So, and that's about all. So,
What would this syringe over here be for, the slip tip?
it's a good question.
Oh, and then what would the second?
So the list that's on the Blakemore tube kit is from Alicia. We started modifying.
Yeah. Oh,
To
so it's gonna be.
change it.
And it hasn't been
So we
updated because we're still kind of
Correct.
making
We've been
changes.
like slowly like,
Yeah,
what are we
I've
using this for? Get rid of that.
this is really nice having this. I haven't seen this.
Kiki and I spent
but
quite some time trying to figure out. Yeah, it was, but yeah.
So yeah, no. Here you could just skip the Lopez valve, and I think this can go directly in here because it's also got a Christmas tree on there, and it's got the clamp. So it's maybe just a little bit more direct, just to have one less piece of equipment. It also just kind of helps differentiate esophageal from gastric. So.
No, just the one for the spoon or whatever.
One thing on my
Yeah. And then keep the Lopez valve for the gastric. Yeah.
You said, like, failing actual reality, obviously, it's an emergency. Are we gonna have time to check the balloon? Do we check the balloon?
Yeah, I mean, honestly, in an emergency situation, most of the time in true practice, you're not going to see somebody test the balloon. You're not going to see them get an X-ray. You're just going to get the balloon up to 500 and start applying pressure.
Okay.
And that's when I've had to do these. That's what I've done. But the instructions are clear that you want to make sure that the balloon's in the right place. Getting an X-ray is a good idea with 100 mLs of air in the balloon. But 100 mLs, if you pull on tension, it's probably going to pop up into the esophagus. So you don't want to start applying pressure until you know that it's in the stomach. You don't want to start applying tension until this is up to 500, and then your weight, 500 mLs of water or saline.
I'm sorry, I missed the part. Where do we tie the rope onto?
So I think these come in handy, so you can just clamp it to one of the things like that, and then now you have something you can loop the rope through. Do you want to zoom in on the setup here?
And if somebody's like not coughing up blood and like everyone's in the ICU.
Are you still recording? So here's the top of the balloon. We have our sphygmomanometer to the esophageal port, a Christmas tree to suction from the gastric aspiration port, and a Lopez valve for the gastric balloon, which you can use a larger slip tip syringe to inflate or deflate. And then a blue clamp to tie things to and apply tension. And running down the tube, we've got the esophageal balloon and the gastric balloon, and then aspiration ports in the stomach so that you can monitor the stomach for blood.